let's start with psychosis. What is it? All right. If I were there with you, I would ask you to tell me. So, I want you to, hopefully you've thought about it, but I want you to check out some of these features that you see here. All right. Psychosis is a severe mental disorder. All right. Why? Because reality has disappeared and the boundaries between what is real and what is hallucination has just dissolved. All right. So the patient essentially does not know when they are in reality versus when they are, for example, hearing voices, smelling a smell, or feeling a touch from what do we call things that are outside of reality? Psychosis. It's really called psychosis. So, another world, and a person who's psychotic may mention things that seem otherworldly. It's a odd experience to be with someone who is not in touch with reality in the moment. All right. So that said, you're going to have a person with disorganized thought processes, right? They're going to just have these like ideas that come one right after the other, and sometimes they don't connect to one another, right? One second the person's talking about what they had for breakfast this morning, the next minute they're declaring martial law because the president told them they could. All right. So again, it's not just the weirdness of what they're saying, it's the fact that they're disorganized in their thinking. All right. And then hallucinations, if I were there with you, I would ask you, what's an example of a hallucination? Hallucinations include all five senses. Okay. I want you to know that hallucinations can be seeing something that's not there, hearing something that's not there, having something tactile. Hallucinations are when it feels as though someone is touching you, but they are not there. What have we covered? Tasting things that are not there. Patients who are in a psychotic state might say they taste blood or they feel like they're eating worms or something like that. So that's another a sense there. What do we still have? Feeling feelings that may not be there. All right. So hallucinations or delusions. You must know the difference between hallucinations and delusions. Okay. Delusions, I would ask you if we were together, are what? Um, they're more like beliefs. All right. So if a hallucination is a sense of something that is not there, delusions are a belief of something that's just not true or not there. So I can have the delusion that I am the president of the United States, right? So, but I'm hallucinating that I was told uh, by the vice president that I should, again, I'll go back to the other example, declare martial law, right? Often these are grandiose ideas as well that they have, ideas that just don't seem like plausible in the real setting. So I don't want to spend too much time on this slide, but psychosis, it is important to understand what's happening in psychosis. The person may be agitated. And remember before when I said agitation isn't just, oh, they seem annoyed, they seem bothered. There's a physical aspect to agitation where it seems like they can't stop moving, or there's just something bothering them. All right. So agitation tends to be a little upsetting to the person as well as the people around them. All right. Bizarre behavior, I mentioned that before. And then blunted or inappropriate emotions, also known as a flat affect. All right. So people go into their mental health clinicals, often nursing students, that is, nervous about that environment, right? Because you don't know who's going to do what when, right? There's an element of um, surprise or possibly, or there's an element of just not knowing what to expect. In those scenarios, seeing someone who's blunted or flat in one moment, but then agitated in another, would have you thinking, yeah, this person could be experiencing psychosis. All right. So usually an interview with the person is what helps you to understand what's happening or what they see. But you have ways as a nurse that you can assess your patient to see if they are in reality. All right. It's called being testing them to see if they're alert and oriented to all four spheres. So you ever heard that? A&O times four or alert and oriented times four, right? If a patient, you ask them the questions that allow you to know that they're alert and oriented in all four spheres, and one of the answers is to your questions might be no or not applicable at this moment. All right, you're going to pass that along to the team and you're going to let them know that this person is disoriented. Okay. All right. So with that said, let's move on to the next slide. So positive symptoms. This is going to be key for you to understand, right? There are positive symptoms, there are negative symptoms. All right. Usually these terms are associated with schizophrenia because schizophrenia just has so many symptoms. All right. So the positive ones, all right, how are we going to talk about the positive ones? When you think of positive, I want you to think of the addition sign or think of adding something. Okay, so positive symptoms are added or excessive behaviors and experiences that are not present in healthy individuals. All right, so added, think of positive as being added symptoms. All right, so have you heard of the dopamine hypothesis? All right, I will just say a quick word about the dopamine hypothesis. Largely, what we understand about schizophrenia has to do with dopamine. All right. And that theory or hypothesis is that an imbalance in dopamine levels within different brain pathways are responsible for the diverse symptoms that we see with psychosis. All right. So, or with schizophrenia. This is a critical foundational concept for us to understand. All right. And especially in terms of like how we're going to treat them. So with that said, dopamine, an excess of dopamine in the mesolimbic pathway. Mesolimbic meaning like the structures in the brain that are in the limbic system. And we talked about those a little bit last week when we looked at those areas, and we'll look at them again. Here, I have some graphics for you guys. All right, so with that said, positive symptoms are going to include hallucinations, most commonly auditory, where a person perceives a sound that's not real. Okay, delusions again, false beliefs, right? They're fixed usually. All right, beliefs. They're not like transient beliefs. They tend to be fixed beliefs, such as like someone's persecuting me. All right, persecutory delusions, the belief that one is being harassed or spied on. All right. And these are, typical in positive symptomology in patients who have schizophrenia. All right. Or they could have these grandiose delusions, right? This inflated sense of their own importance. That's grandiosity. All right. Disorganized thoughts and speech. You can have that, as we mentioned, and then agitation, bizarre behaviors. Those are the positive symptoms. All right. That kind of let us know that this person is probably going to be positive for schizophrenia. All right. So I don't want to confuse the terms too much, but however you need to understand positive and separate that from negative, that's what you should do. Okay. Because you're definitely going to be quizzed on positive symptoms, um, more than a few times, and definitely the NCLEX. It's fair game on the NCLEX. All right. So negative symptoms. We talked a little bit about a couple of these before, but let us focus on what negative symptoms look like. They tend to be deficits or absence of behaviors and functions. Okay, these symptoms happen to usually be caused by dopamine deficit. All right, in the mesocortical pathway. All right, so you've got the mesolimbic pathway and then you've got the mesocortical. I wish I had a graphic here, but I'll show you in a moment. Hopefully, I will remind myself to do that when we get to the structures in the brain. All right, but dopamine deficit in the cortices of the brain, with negative symptoms. Easy enough to remember. If it's dopamine that you can remember as your important neurotransmitter in schizophrenia, then you know the deficits are associated with negative symptoms. All right, and what are negative symptoms? Remember, a little Latin lesson. All right, whenever you see an A in front of one of your medical terminology terms, usually there's something being taken away, removed, or there's a lack of something. All right. So for example, anhedonia, all right? We mentioned that before. Hedonistic people or heathens or hedonites, or when you're showing hedonistic behavior, it's pleasure loving. All you want to do is experience pleasure, pleasure, pleasure. All right. Well, when people have anhedonia, there's a lack of finding joy in things, a lack of pleasure. All right. You see that with depression, as we mentioned before. You definitely see that with schizophrenia. And that might kind of contribute to a lot of the persecutory ideas that someone's out to get me, someone's spying on me, someone's taking something. All right. And that causes, or there is, I won't say it causes it, it's not a causal relationship, but you'll observe in that patient that they just don't seem to be enjoying anything. All right. Avolition. All right. So if volition is like a job, a duty, being motivated to do something, avolition is the loss of that motivation. Okay. All right. Alogia or alogia. All right. Alogia. Log, log, usually has to do with speech, writing, or language. All right. So alogia is a loss or poverty of speech. They don't speak much. All right. So if you observe those individuals with schizophrenia, you'll see that they aren't talking very much, but you can see agitation. Or they aren't talking very much, but when they do talk, they don't seem to be talking to the people in the room. They may appear to be talking to their hallucinations. Okay. So, but generally speaking, they've learned a lot of times how not to speak so much because people might see that they're talking to someone else and they don't want to kind of out themselves as having or experiencing psychosis in the moment. All right, and then flat affect. We mentioned that before. So I hope that you guys are getting a sense of what a schizophrenic person looks like. All right, social withdrawal, flat affect. There are also cognitive symptoms associated with schizophrenia, not just those positive or negative symptoms. You might see that a patient is experiencing, or yeah, we would call it a patient. There are like issues, or they're experiencing the problems with their daily functioning. All right, and adhering to a routine. So in addition to those negative and positive symptoms, we might see an individual with schizophrenia often experiencing cognitive impairments like poor attention, like they can't just give the attention that they need to the moment, right? They're like distracted and like you're trying to talk to them and find out what's going on. And they're just like, huh, they don't quite engage with you. Poor attention, but also impaired working memory. All right. So they can't really remember the way they should. Again, their thinking is a bit off because of the psychosis. So their working memory might be off. Okay, and these might be clues. The disorganized thinking, we're all in that same part of the brain where attention, memory, and thinking, in terms of executive function, which is like how to execute things. That's what executive function is referring to. Like, how do I execute brushing my teeth, right? It's not something you often have to think about. You're just going in there and doing it after learning how to do it, right? But a person who's schizophrenic may have poor hygiene because their executive function is not there in that moment, okay? And again, they're also just giving poor attention to detail. All right, so our overview of schizophrenia, it is a burden, that illness. It actually is. It's not just a medical issue, but it's also a social issue. And imagine the occupational burden that might come with having a period of psychosis interrupt your daily life. All right, so it's a chronic disabling disorder. Usually the onset when I first learned about schizophrenia, I learned that it happens or gets diagnosed around 20, 21. And I think that's a kind of a bit outdated. It's usually an early adulthood, though. Um, but it usually comes around the time that the individual is introduced to their first like major stressors in life. And that's why you'll get college students being diagnosed with it, at the age of like 18 or 19 when they're first experiencing the stressors of having to manage their own lives, right? In order to manage their the difficulty of executive function, right? And now I have to get up, get myself to class. I mean, you guys know what it was like when you were first freshmen and having to figure out how to make everything work without your parents, like maybe waking you up in the morning or, giving you a ride to everything, that kind of thing. So it really can be a burden. Now, but we do see the onset happen, typically as early as adolescence, but usually adolescents, around 15, 16, 17, 18, 19, when those stressors of life start to come on, that's when you can see it. Now, but it is a chronic disease. I mean, there will be relapses and periods of like cogent clarity without the hallucinations, usually brought on by medication therapy. But yeah, there will be periods where despite being on their medications, not making any changes to their medications, that there might be an exacerbation or episode of psychosis. All right, it's really a major disability. All right, dopamine. So we mentioned before, I think I might have previewed this before. I'm sure I did. Um, oh, there's some kind of Microsoft out update that I don't have time to do. All right. Um, Block dopamine to reduce positive symptoms. That is the foundation of pharmacology as it relates to schizophrenia. Block dopamine to reduce those positive symptoms. All right. So beyond dopamine, other neurotransmitters like serotonin and glutamate are implicated in this etiology of schizophrenia, but the disorder's development is also influenced by genetic predisposition, environmental factors, as I mentioned before, like stressors, like external stressors, um, insults like perinatal insults, like hypoxia during birth. All right. Stress is also in there. I mentioned that it could be seen as environmental, but it also could be internal stress. But then also substance abuse. All right. So all of these can influence. Yes, substance abuse can lead to schizophrenia or schizoaffective disorder, where the person has a lot of the schizophrenic symptoms, but they actually were brought on by substance abuse, particularly things around paranoia and possibly delusions. Not delusions, but hallucinations. All right, so what area of the brain are we talking about? We are looking at the mesolimbic pathway, where you get the excessive dopamine leading to positive symptoms. All right, that arrow indicates leading to. All right, and then the mesocortical pathway, where you get the dopamine deficit leading to negative symptoms. All right, serotonin's in there, glutamate are in there as neurotransmitters of importance. However, it's really the dopamine that we're trying to manage and increase. Um, in the case of patients who have negative symptoms, all right, and decrease in the uh, case of patients who have positive symptoms. All right, so what does the brain look like in schizophrenia? We might have larger ventricles in the brain. Take a look at the brain, look at the ventricles. They will be larger in an individual with schizophrenia. Cortical atrophy. Cortical atrophy might include atrophy just means reduction or removal or the loss of use or the loss of function, right? Atrophy. So cortical refers to the cortex of the brain, right? To the majority of the brain that looks like, you know, um, like kind of having those like I don't want to they're called sulcus or sulci is the pronunciation and gyri, but pretty much all the grooves and bumps that are in the brain represent the cortex, right? Some of those inner structures that are embedded in the middle of the brain are more specifically those anatomical features in there, like the hypothalamus and the thalamus and the, you know, pituitary gland. We'll take a look at all that in a minute, would be other structures. All right. So cortical refers to the brain, the larger part of the brain. All right, that gets smaller, that shrinks a little bit in schizophrenic folks. All right, and then the abnormal frontal lobe function. And remember, frontal lobe has a lot to do with the personality, the way you present yourself to the world. Generally speaking, that, you remember from psychology, that guy who had the that bar go through the front of his, or with some kind of projectile go through the front of his prefrontal cortex. And he just went from being a nice, affable guy to being like a rude, you know, angry person. All right. So we're going to get abnormal frontal temporal lobe function, implying that you're going to have issues with the personality, the affect. Okay. All right. So risk factors. What are the risk factors for schizophrenia? We mentioned before, genetic predisposition, perinatal insults, stress, substance abuse, dopamine dysregulation. But do we get this now? The risk factors and etiology associated with schizophrenia have to do with these four factors, okay? All right. Um, the course is that we have the early onset, those folks who do have an early onset, say in their preteens, teens, early teens, those people fare worse or have a poorer prognosis than people who actually develop schizophrenia a little bit later in life. So if we, and you do have individuals who develop schizophrenia in their 20s, later 20s. But the later the onset, the better the prognosis. The earlier the onset, the more, it was kind of like a YouTube video more so. It's not like common that it happened, but I've seen patients as young as 6 or 7 being diagnosed with schizophrenia. All right. There's that case of that girl. That said, the earlier, the poorer the prognosis. Relapse happens all the time with schizophrenia because really the only real way to get control over schizophrenia is to what? Modulate the dopamine. So you do need medication therapy or treatment in order for schizophrenia to truly like subside over time. All right, there's usually a chronic decline, and there's what we would call it's kind of a progressive disease. It gets worse over time. All right, folks who have social support though tend to do better in their course of disease.